Hello, my name is Dr. Norman Lepor. I'm the director of the National Heart Institute in Beverly Hills, California, clinical professor of medicine at the Geffen School of Medicine at UCLA from 2010 to 23, and attending cardiologist at the Smith Cedars-Sinai Heart Institute. Today, we're going to talk about a topic which actually is quite controversial. It's called the role of inflammation and its management in cardiometabolic disease. So there have been some recent headlines in some major newspapers in the United States. For instance, here's a headline from the New York Times that says, inflammaging is chronic, stealthy, and can be a serious threat to your health. So if it's in the New York Times, so it must be true, right? And then even in the Wall Street Journal, we see a headline, a new way to protect against heart attacks. It is increasingly clear to researchers that inflammation can raise the risk of a heart attack. Now doctors have a drug that addresses that risk. And I think after this presentation, rather than a period, we'll actually have a question mark. And then, of course, the Wall Street Journal again has an essay on rethinking the origins of inflammatory diseases. Research on how the immune system can go wrong is changing the way medicine thinks about everything from COVID-19 to heart disease. So we now see the issue of inflammation, particularly relating to heart disease, is now becoming mainstream among lay people, as it certainly, as we all certainly become more aware based on the headlines, the recent headlines, in fact, from the two very important periodicals. So let's try to dissect things out a bit and try to figure out, well, what is the role of inflammation in terms of residual risk? Meaning, once we've taken care of all the risk factors that we know of, what is the leftover that may be related to inflammation? And what we can see here in this pie chart, if you go to the right upper part, you see that in patients that you've already done a pretty good job of getting their cholesterols down to goal levels, in this case, LDLs less than 70 milligrams per deciliter, and you say, well, what percent of the population has residual inflammation? And this is defined as a high sensitivity CRP level of 2 milligrams per liter or higher. We see that in about 1/3 of patients, we have this residual inflammatory risk for patients in terms of the risk of developing cardiovascular disease. And so we say, well, okay, we've identified that risk. Now, is there something that we can do about it? And that's going to be we'll discuss in the later part of this presentation. So we're looking here now in terms of residual risk in secondary prevention of atherosclerotic coronary vascular disease. And what we can see here, looking at the various factors that predispose to heart disease, residual inflammatory risk, residual cholesterol risk, residual thrombotic risk, residual triglyceride risk, LPA risk, and diabetes risk, we do have a marker, a critical biomarker for inflammation, as we do for many of these other risk factors, and that is the high sensitivity CRP. And we define a patient who would be considered inflamed with a hsCRP of 2 milligrams per liter or greater. And you can see along the lines the definition of significant residual risk with LDL. Some would argue that that number perhaps should be greater than 70. There's no simple biomarker for residual thrombotic risk. We know that triglyceride risk and the triglyceride-rich lipoproteins are very atherogenic. We're looking at triglyceride levels certainly above 150 milligrams per deciliter as residual risk. As you all know, I'm very involved with issues related to lipoprotein(a) treatments, and we're looking at an LPA level of 50 milligrams per deciliter and above as prompting a higher risk situation. That 50 milligram per deciliter is basically equal to about 125 nanomole per liter. And we have a biomarker for diabetes because we know that diabetes as a syndrome plays an important role. So we know that that the inflammation plays a role in atherosclerotic cardiovascular disease, and we actually have some targeted inflammation markers or targeted inflammation reduction we'll talk about in a bit. And there actually has been a fair amount of randomized clinical trial evidence that interventions targeting IL-1, targeting other factors that we're going to be talking about, may actually reduce that residual cardiovascular risk. So I think it's clear from early work with Dr. Fuster and others that I think we can all agree that inflammation plays a key role in the development of atherosclerotic disease. We know that a whole variety of inflammatory cells, neutrophils, T cells, B cells, uh, put out cytokines and other compounds, activate the inflammatory cascade. We're going to talk a lot about this inflammasome, which is targeted by colchicine in terms of our ability to impact the inflammatory process. The inflammasome is very much involved in activating interleukin-1 beta into its more active component, which plays a very important role in the development of inflammation associated atherosclerotic disease. So we know that inflammation really plays a very important role. There are a whole variety of factors involved in inflammation-mediated effect on atherosclerotic uh, vessels. And this could include, again, TNF alpha, tumor necrosis factor, interleukin-1 beta, the development of reactive oxygen species, the macrophage and the inflammation and metalloproteinases, which have an effect in terms of thinning the cap. And all these lead to the development and promotion of atherosclerosis and ultimately thrombosis. So we have lots of targets that potentially may impact our ability to affect this atherosclerotic and thrombotic process. So what we see here, as you go from left to right and down this way, we can see this kind of time-lapse photography in terms of what the role of the inflammatory cells and inflammation play in the actual development of plaque and the predisposition of that plaque to rupture. So we have, in the initial phases, we have leukocyte migration, we have the adhesion to the endothelium of these inflammatory cells, and therefore they put out their own compounds that lead to accumulation of accumulation of other inflammatory cells, such as T cells, macrophages. This leads to the development of the plaque within, for instance, in this case, a coronary artery, but it could be a carotid artery or a peripheral artery. We have adherence and aggregation of platelets. We're starting to develop this more mature atherosclerotic plaque. Now we're seeing macrophage accumulation, the development of the fibrous cap. The fibrous cap actually protects the vessel from the components under the cap that are very thrombogenic and inflammatory. And of course, to a large extent, the macrophage plays a very important role in terms of actually thinning this fibrous cap, and that would be by virtue of the metalloproteinases and other cytokines, leading to thinning of this fibrous cap, predisposing to plaque rupture, and the final sentinel event, a hemorrhage and thrombosis. So these are some of the mediators of inflammation, and many of them are related to risk factors that we try to mitigate. We know that smoking, dyslipidemia by virtue of oxidized LDLs, oxidized fatty acids, ApoC3 mediate inflammation. We're learning more and more about how the gut and the microbiome play a very important role in terms of the inflammatory process. Hence, reasons why we want to reduce the consumption of animal products, meats, et cetera, which actually affect the microbiome and predispose to inflammation. Perivascular fat, it could be fat that surrounds the arteries, fat that surrounds the heart, are very much involved in the inflammatory process via tumor necrosis factor, adenopectin, reactive oxygen species. And visceral adipose tissue plays a very important role. This is the fat that surrounds, key organs. We know now that the adipocyte is not a benign entity. It's actually basically a factory for inflammatory cells and cytokines. We know that diabetes, or the insulin resistance syndrome, is associated with oxidative stresses, its own dyslipidemia with elevated triglycerides, excess free fatty acids, and these reactive oxygen species. So there's a lot of factors involved with the increase in inflammation, and many of these mediators are things that we can control. with various treatments and various lifestyle modifications. So here's, for instance, a vicious cycle of inflammation. This is looking at in diabetes, for instance. Diabetes really is significantly affected by the inflammatory milieu. You can see the pancreatic islet cells here, and they're being basically stormed by a whole variety of inflammation mitigators, such as inflammation enhancers, such as inflammatory cytokines, these natural killer cells, macrophages, T cells, B cells, basically a variety of these mediators of inflammation, leading to beta cell dysfunction and early beta cell demise, which predisposes to the development of type 2 diabetes. So this is looking at actually the influence of interleukin-6, which is a major inflammatory compound, and CRP levels, and the development of diabetes. And what we can see here is, particularly when it comes to interleukin-6 levels, but also C-reactive protein, as you go from the first quartile to the fourth quartile in terms of increasing levels, you can see that the relative risk, the adjusted risk for the development of diabetes, more than doubles when you have this elevated interleukin-6 level, which is an indicator of inflammation. And in fact, it's a mediator of inflammation itself. We see that a similar story is seen with C-reactive protein, where after adjustments, your chance of developing diabetes compared to the first quartile is basically 4 times. So the development in this case of diabetes, just as a disease state that's important, it's prevalent, significantly increases a cardiovascular risk. Inflammation markers are associated with a significantly elevated risk, in this case, of developing diabetes. So what kinds of anti-inflammatory interventions? So it's great to know that inflammation is involved with the development of atherosclerosis and atherosclerotic events. So what are some of the anti-inflammatory interventions that actually we may be able to apply at this time? Well, we know that statins, as terms of their pleiotropic effects, have the ability to lower inflammation markers, and therefore we feel that it has its own anti-inflammatory effect, both systemically and at the blood vessel level. We'll show evidence regarding the use of low-dose colchicine. I'll show some updated evidence that was just presented at the American Heart Association meeting about 2 weeks ago. We'll talk about the impact of anti-IL-1 beta antibodies. We'll also discuss briefly about anti-IL-6 antibodies, many of which are actually in current clinical trial, and I'm involved in 2 of those trials. One is Hermes, and the other is the Zeus trial. And there's evidence that low-dose interleukin-2, which is actually a protective anti-inflammatory compound. All these are approaches to and interventions to fight inflammation. So this is an important publication. I urge you all to look it up in Metabolism, just published earlier this year, the DCRM. It's a multi-specialty recommendations for the management of a whole variety of disease states, diabetes, cardiorenal, and metabolic diseases. So I urge you to review this. This was developed under the leadership of Dr. Yehuda Handelsman. And we actually developed a recommendation for inflammation. We defined inflammation as either by hsCRP or urine albumin creatinine ratio. We know that a urine albumin creatinine ratio greater than 30 milligrams per gram or 3 milligrams per millimole is associated with inflammation. It's very important that you not just assess this in patients who are diabetics, looking for nephropathy, but you're also looking at it in general to complement the hsCRP measure. We know that inflammation is involved in terms of recurrent cardiovascular events, and we feel that worthy recommendations on the right here include lifestyle modification, Mediterranean diet, regular exercise, if overweight or pre-diabetic, 5 to 10% weight reduction with lifestyle if obesity intensified to pharmacotherapy or other interventions as negative, as indicated. And in terms of the actual treatment options, many of these treatments, for instance, that we treat lipids for actually have anti-inflammatory effects. We see that with statins, ezetimibe, bempedoic acid in particular has been shown to significantly reduce inflammation as well as reduce primary cardiovascular events, primary risk prevention. Hypertriglyceridemia with the use of IPE, eicosapentaenoic acid in particular. This does not relate to other omega-3 oils, but actually just eicosapentaenoic acid has been shown to impact triglycerides, cardiovascular events, and inflammation. Treating obesity, we know that the adipocyte is basically a factory of inflammation, and we're looking and seeing the effects of GLP-1 RAs as important therapies, not just for diabetes and obesity, but relating to their anti-inflammatory effects. A long forgotten treatment for diabetes, pioglitazone, actually deserves to be, to be more widely considered for treating diabetes, has anti-inflammatory effects, and so does SGLT2, the SGLT2 inhibitors. In terms of direct anti-inflammatory medications, we're looking at chronic inflammation and atherosclerotic coronary vascular disease, and we're going to talk a bit about colchicine, which had a lot of good news, but a recent trial, though, I think has us rethinking the role of colchicine in terms of mitigating cardiovascular risk through that approach. So we're looking at the favorable effects of lipid lowering in experimentally produced atherosclerotic plaques. So using statins and perhaps bempedoic acid and such. We know that lowering lipid levels, particularly LDL, reduces inflammation. It reduces the expression of interstitial collagenases, which actually lead to a thinning of that cap on the plaque, which predisposes to plaque rupture and thrombosis. It increases the levels of interstitial collagen. It lowers the levels of oxidized LDL, low-density lipoproteins. These are of the most atherogenic type. It reduces the production of reactive oxygen species, increases the expression of endothelial nitric oxide synthase, and reduces thrombotic potential, as well as increases fibrinolytic potential. So these are some of the positive effects produced by lipid lowering, and many of these are manifested by effect on inflammation. Well, let's look at some of the strategies to inhibit inflammation, atherosclerotic coronary vascular disease. So we'll talk about the NLRP3 inflammasome, which is really a series of macromolecules. And what the NLRP inflammasome is most notorious for is activating interleukin-1 beta to its active component so that it can play a very important role in the inflammatory cascade. And colchicine actually targets the NLRP inflammasome, and we'll talk about some of the pleiotropic effects of colchicine. And it's felt that by blocking the activation of IL-1 beta, you have a variety of effects, one of which is blocking the production of IL-6, leading to reductions of inflammation and the inflammatory marker CRP. We also have evidence that an antibody against IL-1 beta, so it actually binds to IL-1 beta, canakinumab, and this was in the CANTOS trial, a trial that I participated in looking at patients who had a history of myocardial infarction, elevated inflammatory markers, showing a positive cardiovascular risk, about a 15% reduction of events. There are a variety of compounds that affect the interleukin-6, and the one compound that I'm working with in the 2 clinical trials is looking at ziltivekimab, and it's actually an antibody against interleukin-6. So you figure if we get rid of interleukin-6, decrease the hepatic production of CRP, decrease the inflammatory milieu, that potentially may have positive effects on the development of atherosclerotic events. So this is looking at the CANTOS trial. So the CANTOS trial looked at canakinumab, which was an antibody against IL-1 beta. And this is looking at the level. This is a post-ad hoc analysis of the primary cardiovascular endpoint at post 3 months. And what they found in this particular study, that you were able to actually induce a significant reduction of cardiovascular events through the use of this technology. So what the CANTOS showed is the effect of inflammation that lowered cardiovascular events by about 36% in this particular sub-analysis. This is when the interleukin-6 levels were below 1.65 nanogram per liter. So what this shows is that by blocking IL-1 beta, you therefore reduce the concentrations of IL-6. And in those patients where you had that effect, you're able to reduce cardiovascular events by 36%. And this occurred pretty early on in the clinical trial. You were able to see the curve spread somewhere around the 6-month level. So this goes along and with the fact that inflammation, by blocking inflammation mediators, you can actually reduce cardiovascular events. Well, let's talk about colchicine. The headlines that you saw earlier from the Wall Street Journal and New York Times really related to the colchicine effect. And what in a recent meta-analysis of 5 studies did show about a 25% reduction of the cardiovascular events with colchicine versus placebo. That showed the significant reduction of risk of MI, 22%, stroke, 46%, coronary revascularization, 23%, no significant effect on cardiovascular death. And one of the effects of colchicine is blocking the development of this inflammasome, which is really a compilation of different enzymes, caspase-1 and other components. And this inflammasome is what's involved in activating interleukin-1 beta, and colchicine blocks that effect. Colchicine also blocks the neutrophil platelet interaction, and thereby and neutrophil adhesion and activation. And again, these are thought to play a role in the protective effects that colchicine was observed in these trials. So these are the anti-inflammatory targets of colchicine. So they inhibit neutrophil migration, adhesion, and activation. Remember, that was one of the early aspects in terms of development of plaque. It blocks this NLRP3 inflammasome, which blocks the activation of interleukin-1 beta. It blocks the release of granules from the neutrophil, leading to potential decreasing endothelial injury and decreased risk of atherothrombosis, and has protective effects in terms of smooth muscle proliferation. The end effect of interleukin-1 beta is when activated by this inflammasome leads to the increased production of IL-6. IL-6 has direct effects on the liver in terms of its synthesis of C-reactive protein and as a marker of inflammation. One of the problems with colchicine that you need to be careful about, it actually has many drug-drug interactions because of its metabolism of cytochrome P453A4 and P-glycoprotein. I think this would be a good slide to keep around as you prescribe colchicine, so that you can be aware of some of the more important drug-drug interactions. Well, here's the story with colchicine. So the LODOCO-1 trial, this was looking at patients with stable coronary artery disease, and it was a moderately, it was a trial that was, wasn't one of the big CV outcome trials, but it did have about 500 patients, over 500 patients enrolled. And what they found in this trial was about a hazard ratio of 0.33 for cardiovascular events. So they're talking about a 60+% reduction of cardiovascular events with colchicine versus placebo. That was LODOCO-1. LODOCO-2 was a follow-up trial, again looking in patients with chronic coronary artery disease. And what they showed is this reduction of the primary composite endpoint of about 31%, consistent. So LODOCO-1 and LODOCO-2 were pretty consistent. We had the safety and efficacy of colchicine. This is looking at patients post-MI in the COLCOT trial. And here we're seeing a statistically significant reduction of about 23% in terms of the incidence of the composite endpoint. So we're seeing in these clinical trials evidence of significant protection using colchicine, presumably because of its anti-inflammatory effects. Using invasive intracoronary technology such as OCT, we actually found in patients who were on colchicine that the fibrous cap was thicker in those patients on colchicine. You can see by the arrows versus those patients who are on placebo. And so this is something that you would feel is reasonable if you reduce inflammation, you reduce the metalloproteinases that lead to the thinning of the cap and predisposition to thrombosis. So at this point, you would say, hey, this is a really good study. This is a really a good amount of evidence supporting the use of colchicine. And I actually prescribed it a fair amount in my higher risk patients. And then at the American Heart Meeting, we had the presentation of the CLEAR Oasis 9 trial. This was a very large trial of about 7,000 patients. And they looked at patients who had suffered either a ST elevation or a non-ST elevation myocardial infarction. And in this trial, they were looking at the effect not only of colchicine, but also of spironolactone. There's a maximum of 5-year follow-up. The primary composite endpoint for the colchicine versus placebo was time to event composite of CV death, recurrent MI, stroke, or unplanned ischemia-driven revascularization. And although we don't have the publication yet, here was the actually this was presented at TCT. This was the headline: Colchicine goes belly up in a more definitive heart attack trial. Larger, clearer Oasis 9 trial could not replicate past results. Basically, there is no difference in terms of CV death, MI, stroke, ischemia-driven revascularization, and the only clinically significant signal was the increased incidence of the GI side effect of colchicine, which was diarrhea. So this kind of puts a little bit of a a negative ring to the colchicine story. So you have data previously showing a series of trials looking at the efficacy. Most of those trials were looking at chronic coronary artery disease, and this was an acute trial looking at patients with a very recent MI, and the results, although we don't have the publication yet, were negative. So now we're looking at another mediator of inflammation, IL-6. And we know that IL-6 plays a very important role in inflammation and in the development of atherosclerosis and plaque rupture. There are a variety of compounds that actually affect interleukin-6 at different sites. As mentioned, we're looking at ziltivekimab in 2 clinical trials. And in terms of it being an antibody blocking IL-6. And the speculation is that by blocking IL-6, we would have an impact on affecting all of these components of the inflammatory cascade: cytotoxic, oxidized LDL levels, the potential for clot and thrombin development, other cytokines, and perhaps by virtue of this IL-6, even in terms of protecting cardiomyocytes. We're looking at this compound in patients who have heart failure, as well as patients with coronary artery disease. So this will be these will be really important trials testing the inflammation hypothesis, particularly because of now the mixed information that we have available regarding colchicine. So in summary, we know that inflammation plays an important role in the development and complications of ASCVD and a host of metabolic abnormalities. The role of anti-inflammation treatment has been confirmed in the COUNTOS trial. The precise role of colchicine in reducing ASCVD risk is now not clear, and newer approaches targeting IL-6 are being actively investigated in clinical trials, and we eagerly await those results in the coming years. Thank you very much for your attention, and I hope you're able to gain some important information on inflammation and how it can be targeted. Thank you very much.